Good morning. My name is Belinda Blair. I'm a graduate student at Eastern Kentucky University and an oncology nurse. I am doing an integrative review on establishing protocols for lower extremity lymphedema in cancer patients. There's a lot of literature on upper extremity edema, but very little on lower extremity edema. The recommended methods in most of the articles you'll find are going to be 5 days a week, physical therapy by a lymphedema certified therapist. It's complete decongestive therapy with manual lymph drainage, which basically they're moving by massage techniques the fluid back, through the lymph system. It's multi-layer bandaging, exercise, compression garments. But there's not a lot of evidence to support that. It's just this is what we think we should do. The case studies that I'm going to show will show that it did help these patients, but there just hasn't been enough research to really say there's a lot of literature to support it. So what is lymphedema? Lymphedema is protein-rich fluid that pools in the interstitial space. It's caused by trauma, surgery, tumors, radiation, chemo, infections, various things, burns. There was a study by Fu, Ryan, and Cleland, 2012. It was a web-based study. It was cross-sectional and correlational, and they found that oncology nurse navigators, surprisingly, knew more about lower extremity lymphedema than clinical nurse specialists or advanced practice nurses. And the question that I want to raise is if you only have about 3 oncology nurse navigators at an institution, you can obviously see, correct, that this is a major disadvantage to our patients. For the email survey that they sent, there was 2,510 nurses that received it. Only 256 responded. 21 of them were oncology nurse navigators. The next question I'm going to raise is there a knowledge deficit amongst physicians? And I believe there is from my practice, but I wanted some literature to back that up. So I looked at one case study by Holt-Grief in 2006. It was only one patient. What they found was a patient who had signs and symptoms of lymphedema. They self-referred themselves to a gynecologist. They went and saw the gynecologist. The gynecologist said, not really sure what to do with this, so he sent the patient to a surgical oncologist. Surgical oncologist didn't know what to do with the patient, so he went and talked to an oncology nurse who recommended that they send her to a physical therapy lymphedema certified therapist, which is what they did. So the next case study I'm going to talk to you about is actually about the regimens that are being used, the manual lymph drainage and compression garments, exercise, multi-layer bandaging, and the complete decongestive treatment. The next study was by Green and Fowler. It was in 2008. They had a 24-year-old who presented with lymphedema in both legs. She was recommended for 5 times a week therapy, that she would go into the office and have all of the recommended therapies done. She had weekly girth measurements. The last week was not reported, which is disconcerting. The method of measurement was the Jopes Alvarex board, and the results were she did not want to do the 5 weeks. After a few weeks, she said, we got to do it twice a week. It's just too much. She had to work. So what we did resulted in week 9, she had a 15-pound weight loss, and she was able to wear normal clothes, which was great. Unfortunately, they did not do measurements at the last time she had therapy. The next case study is by Holt-Grief, 2006. It was a 55-year-old with a twice-weekly regimen of the same things, the complete decongestive therapy, the manual lymph drainage, multi-layer bandaging, exercise, and compression garments. She had weekly girth measurements. They used a pen, marked 6 levels, did 3 measurements of each area and averaged for each site. And the other things they looked at was pain, which was severe when she began. Function, she couldn't do ADL. She was using her upper arms to move herself. The result was a 10% reduction in her right lower extremity, 9% on the left. Was able to return to her baseline function, and the pain was gone after 1 treatment. So you can see how that is a major benefit to this patient. The last study I'm going to tell you about is by Ridner, McMahon, Dietrich, and Hoy in 2008. And it was about the Flexitouch system. And it was used in conjunction with exercise compression garments, bandaging, and elevation. This system can be done at home, which is a great benefit to the patient, but it was quasi-experimental. It was a convenient sample of 241 people who were prescribed the Flexitouch by the provider. There was a pre-survey 5-point scale with 8 subscales regarding general health, physical functioning, roles, bodily pain, mental health, vitality, social function, and 155 completed the post-survey out of the 241. There were no things that talked about the attrition or why it occurred, which is disconcerting. The results of the surveys did show 90% were very satisfied with the results and 7% were unsatisfied. Of the unsatisfied, most of them were not adhering to the recommended treatment modality. So, in conclusion, with nursing implications, anybody that's knowledgeable in lymphedema has to find ways to educate the staff where they work. We also need to be seeking out opportunities to learn all that we can and do current literature searches regularly to see if anything new is coming out. I would also encourage nurses alike, advanced practice nurses, to look at designing their own study and going to the IRB to get some literature and evidence to back up this modality. Thank you so much and have a great day.